Hello everyone, this is Sean Fox, and welcome to the Pediatric EM Morsels ReMastered. As many of you know, I've been sending out the PDM morsels every Friday for the past almost 4 years now, and I wanted to explore a new way to deliver them to you, and in addition to re-release some of the previous morsels that are still, I think, valuable and fun to think about, but may have gone undiscovered. And I figure if Star Wars can be re-released multiple times, why not the morsels? Many of you already know that the Pediatric EM morsels are available on the website at pdmmorsels.com, and you also know that if you go and click on the little envelope there, you're able to subscribe so that you can receive them in your email box on Fridays, and also you're able to follow on Twitter. For those of you that have been doing that, I greatly appreciate your time and your efforts and your comments. Additionally, I need to add some appreciation to my colleagues and mentors, Drs. Mattu and Rogers from University of Maryland, where I initially trained, and have been long-standing supporters and mentors of mine. And in addition to Dr. Cadigan, Mike Cadigan down in Australia, who helped me transition from an antiquated way to a much more meaningful and significant technology, which I appreciate. So thank you all, gentlemen. But more importantly, or at least as important, I must extend my thanks and gratitude to my residents at Carolinas Medical Center here in Charlotte, North Carolina, as they continue to encourage me and push me to do better and strive to improve, which I really appreciate. So thank you, everyone. And without further ado, why don't we address two morsels that have been covered in the past that do not deserve to be forgotten, certainly. We all know the Caduceus cookie here, so let's delve into one of these morsels here. Part of our job, certainly part that many of us enjoy the most, is doing procedures. However, when you start doing procedures on children, the difficulty increases. Why? Because the target areas for all of your procedures are smaller. Also, there are anatomic considerations in addition to different physiologic responses. However, I think that with some guidance and some anticipation, we are able to be as successful at doing our procedures in pediatric patients as we are in adult patients. Let's cover just two procedures here today with our review. One being a procedure we do almost every day, and another that many of us probably have never done and hopefully will never have to do, but need to know about. So first, lumbar punctures. Without question, this is a procedure we do countless times. Many times we do it numerous times in a single shift, and I think most of us are very comfortable with it, but it still deserves some attention, as complacency can lead to problems. So first and foremost, what I need to stress is that I believe monitors are vital in this procedure. Why? Because most of the time you're doing the procedure, you're doing it on a very young child who has an airway that is very malleable and easily collapsed by simple positioning. Just by merely flexing their neck, you can easily occlude their airway. And so you started off doing a procedure because you were worried about the child because of a fever, and now you've caused them to stop breathing because of a position that you've placed them in. In addition, many times that you're doing the procedure, it is for a fever workup, and most often that fever is due to or attributable to a viral illness, which is many times causing their nose to have a bunch of snot in it. And in the very young who are obligate nasal breathers, you combine that fact with the fact that now they've got a bunch of rhinorrhea, and then you put them in a position that already is placing their upper airway at in a position that is potentially occluded. You've now increased their risk substantially for not being able to adequately ventilate. And I unfortunately have experienced this firsthand when I was a second-year resident not so long ago, and that memory is well burned into my memory. And I remember thinking that while the lumbar puncture that my colleague had done was successful, we did the patient no good because we caused them to have a resuscitation. So while a successful LP does deserve commendations, there aren't any rewards given if you have to do a resuscitation for the patient afterwards. So be dogmatic, place the patient on a monitor, and even some nasal cannula oxygen. If you can do nasal cannula assisted end-tidal CO2, that's even better. Additionally, make your first attempt your best attempt. Just like you want your first attempt at intubation to be your best attempt so that it is successful, you want your first attempt at a lumbar puncture, particularly in the very young, the neonate, the 2-month-old, to be your best attempt, because every subsequent attempt after that becomes more difficult and is going to much more likely have significant blood in the CSF, making your interpretation of that information more difficult. So make sure you position the patient correctly, double check your positioning multiple times, double check before you sterile field, and double check after you've done the sterile field. Make sure that nothing has moved. Additionally, I do like the use of topical lidocaine like LMX and the use of oral sucrose to help decrease the squirming, particularly in the very young kids. They will squirm, and the tiny little target that you had before now is moved considerably, whereas an adult who moves, you still have a large target, and the degree that it has moved is a lot less than the degree that the neonate's spine has moved when they squirm. So if you can decrease that squirming, you'll increase your risk. You'll increase your chances of being successful, and you want that first attempt to be your best attempt. But most importantly, it is about positioning. We all know that your success at doing a lumbar puncture is completely predicted by the holder. And most holders I've encountered will make your patient into the shape of a donut, which we've already discussed is an issue with their airway, but it's also not advantageous to the success of your procedure. A very nice study with the use of ultrasound was done, and it showed that the largest space of the interspinous space was achieved when the child was upright and their hips were flexed, and had nothing to do with their neck flexion. Neck flexion did not change their interspinous space in the lumbar region. So you don't need to make them into a shape of a donut. You need to focus on keeping their spine nice and perpendicular to their pelvis, and to really flex those hips under. Whether you put them in a lateral decubitus or sitting position, focus on making sure those hips are flexed, and then your success will increase. So that's a simple little procedure that most of us are very comfortable with. Well, what about a very scary procedure, but the most important one that all of us need to know how to do? Transtracheal ventilation. What I think is interesting is that it honestly is the easiest procedure. It's probably even easier than placing an IV, because your target's relatively big, and all you're doing is putting a catheter through the neck. Now, obviously, this is a little bit bigger than a neonate or a child, but that's the simple procedure. It matters most how you attach the oxygen afterwards. So the biggest problem that I find with this procedure is knowing when to do it, and essentially it's the same time that you would be pulling the trigger to do a crike, so the I can't intubate and I can't ventilate situation, and also the child is too small to do a crike on. Remembering that most guidelines will say that a child less than 8 years of age, you need to consider transtracheal ventilation. Some literature will actually say children less than 5 years of age. It's really a size thing. We've all seen kids that are 5 years old and are big, and we've all seen 8-year-old kids that are small. So if you think that your child is going to be too small for you to be able to fit a crike tube through, then you need to think about transtracheal ventilation. What's interesting about transtracheal ventilation is you can actually do it on adults, and there's been studies that have shown adults that have been transtracheally ventilated successfully for 24 hours. So it's not something that you just need to consider in kids. You can actually use it in all ages. But as I said, after figuring out you need to do it, the procedure itself is simple, and then the hard part comes in trying to figure out how you attach oxygen to it. So if you're fortunate and you work at Caroline's Medical Center like I do, in Levine Children's, you have a manufactured commercial ventilator which hooks up to your oxygen and hooks up to the catheter in the neck, and then you just essentially use it. Or you can be MacGyver and make your own with oxygen tubing, a Y connector, and a lure lock. The ratio that you'd want to use to ventilate someone this way would be 1 second of inspiration to 4 seconds of exhalation. The child that has a completely occluded airway and that no gases are escaping through their mouth, then you're going to want a longer exhalation phase of 1 second on to 9 seconds off. So normal would be 1 to 4, completely occluded would be 1 to 9. But what if you don't have a oxygen tubing or ventilator setup ready to go? What else can you do? Well, many of us know that there are some ways to attach a bag valve mask or bag valve. You can use a 3.0 ET tubes bag connector or a 7.5 in conjunction with a 3 ml syringe. Now, I prefer the 7.5 to the 3 ml syringe in the 3 ml syringe just because it gives you some more space to deal with. It's a little bit longer. You're able to use the syringe to lure lock down on the catheter, and that allows you a little bit more space away from the child's neck. Now, this is just a typical 18-gauge angiocath, but ideally you'd be using a transtracheal needle catheter. But in a pinch, you can do that. And speaking of in a pinch, many times when that moment arises, you're not going to be able to remember all of these things. Remember that you need a 7.5 endotracheal tube bag connector attached to the 3 ml syringe along with your transtracheal needle, or oxygen Y connectors with oxygen tubing to set up. So make it so that you don't have to remember those numbers, and just get a Ziploc bag and put these devices in them and tape it to the wall and write in case of emergency. I would also recommend a change of pants for yourself, because you never know. So with that, that's a little voyage through two of the morsels that we've remastered. They have been delivered previously, and I hope you enjoyed them this time. Please, I really appreciate your comments, any suggestions, any feedback. Send it to me at smfoxmd@gmail, or by all means, you can also add comments at the websites pdmmorsels.com or MedEdMasters, the sister site. And with that, I really appreciate your time and look forward to bringing you these PDM Morsels Remastered. Thank you.